Hello, I'm Rob Pilarski. I'm a genetic counselor and professor at The Ohio State University's James Comprehensive Cancer Center. I've been doing cancer genetics for over 25 years now, and I'm going to be speaking on testing capabilities with prostate cancer. The objectives for the day are to review the current testing options for prostate cancer, discussing the pros and cons of some of those various options, to review or at least allude to testing criteria for choosing a quality lab, and then discuss concerns with direct-to-consumer testing. So genetic testing for prostate cancer is becoming increasingly important, not only for determining risk for patients and family members, but more so now for guiding treatment and management. I think it's clear that single gene testing has been supplanted for the most part by panel testing, often because there's more than one gene that could explain the clinical presentation, but also for cost and time efficiency. However, there are various panel types and sizes available, which makes choosing a test more difficult. Insurance coverage is often available, which is quite a change from the past. For many insurers, coverage criteria are based on BRCA testing criteria, but this often includes coverage for metastatic and high-grade prostate cancer. I should note that there is some resistance among payers to cover panel testing, mostly for concern that it could lead to questionable management and screening costs downstream. The labs often get around this by only billing for the BRCA or the Lynch syndrome component of the panel and writing off the rest of the costs. So we are getting panels covered, but not really coverage for the whole panel. The issues also arise regarding clinical actionability, and there are concerns that not all of the genes that are on some panels actually have clearly defined cancer risks or clearly defined management recommendations. And some have argued that we should not be testing these. Others feel that we should test broadly at this point in time, pending future management changes. As with any genetic testing, there are also issues with whether variants that are identified through genetic testing are actually clearly deleterious or cancer-causing. Laboratories generally curate this for us, but it can be cross-checked through resources such as ClinVar. So panel testing comes in a number of forms, and there are pros and cons with each of these. Prostate-specific panels, the pros is that they're only looking at genes related to prostate cancer. Some panels would include only genes that are clearly known to be connected, and others will include genes that are suspected to be. So it gets you a narrow focus and essentially doesn't get you into trouble with testing genes for other cancers that are unrelated to your patient. At the same time, this may miss genes that at this point are not proven to be connected, but may be connected later. And a good example is the Lynch syndrome genes, which until recently were not thought to be related to prostate cancer and would not have been included on panels. Guideline-based panels are a little more conservative clinically. These look at only genes for which there are clinical guidelines or clinically actionable, so that there is agreement on how to manage patients who have mutations in those genes. The drawbacks of these are, especially for prostate cancer, it's not clear what is a clinically actionable gene at this point, and it could leave out genes such as HOXB13 for which there are not guidelines at this point, and yet people feel that they are clearly cancer-related. And finally, there are comprehensive cancer panels, or some people refer to as pan-cancer panels. These cover anywhere from 30 to 80 genes, covering a broad range of cancer risks. Usually these include a number of genes that are not clinically actionable, and oftentimes genes for which we're not even certain of the risks and the various cancers that they're associated with. The pro is that it will identify the largest number of patients at risk for any cancer, but in the process you're going to identify mutations in genes that are not related to prostate cancer, mutations in genes that are not clinically actionable, and you'll get the highest rate of getting a certain variants when you do a broad panel. Here's an example of sort of the current prostate-specific panels that are available from different laboratories. Not all labs have prostate-specific panels, but you'll notice even in these labs there's a fairly wide range of which genes are available depending on the lab you choose. So we now have multiple labs to choose from, including some of questionable quality. I'm not going to go through these in detail, but there are a number of questions that could be asked when choosing a laboratory, some of which can be clear upfront and others need a bit of research to find them. There are also multiple ways or pathways to panel testing. The traditional model, provider-driven, is usually done through genetics programs. The provider initiates the testing based on the patient history. This usually includes pre- and post-test comprehensive counseling with the patient. This type of testing and counseling is generally covered by insurance if testing criteria are met, and the results in these cases are delivered or disclosed by the counseling provider. Recently, we've had an upswing in consumer-driven or direct-to-consumer testing. This is more often patient-initiated, and it can either be based on their own history or their own curiosity. So the patient reaches out to the testing laboratory in order to obtain testing directly themselves. Typically, this includes fairly minimal counseling and education, although some programs are including counseling as part of the process. Mostly they are self-pay processes, but some insurances may cover. And the results are generally not given by the patient's own provider, but through the testing laboratory. The concern with this is it leads to a higher chance of the patient misunderstanding the meaning of the results. And most recently, our direct-to-provider testing. These are cases where a laboratory reaches out to providers who are not necessarily experienced themselves in genetic testing, but the marketing to them. The provider obviously needs to have some degree of genetics knowledge and experience, though, to maneuver this. There may be limited pre-test information or counseling for the patient, which again can lead to a higher level of patient misunderstanding. Within the direct-to-consumer realm, there are a range of, test types or quality. Something like the 23andMe model, which is very common, which is widely marketed and well known by patients, is essentially of no value for prostate cancer testing. They directly sequence a fairly small number of genes, and none of those are the prostate-specific genes. The BRCA testing offered by 23andMe is only for the found mutations that are common in Ashkenazi Jewish populations. And even for that group, if negative, it may be worthwhile doing a broader testing. Most of the sort of gene assessment or risk assessments done by labs like 23 are more association tests, meaning they've got various genetic markers that are statistically associated with prostate cancer or other diseases, but we don't have a direct causative connection there. So they can suggest increased risk, but not necessarily management or inheritance. What's concerning is that there are now ways that patients can get their raw data from 23andMe, which includes sequencing of genes such as HOXB13 or other prostate cancer genes that 23andMe is not allowed to analyze and release or report on. But patients can take this and go to a third party and have those results interpreted by them. The problem is neither 23andMe nor the third party are regulated by the FDA to do this. And there's evidence from at least one small study that there could be as high as a 40% false positive rate, meaning the third-party interpretation that a mutation is present is wrong 40% of the time. At the other end of the spectrum are more responsible programs. Invitae, one of the major testing laboratories, now has what they call a sponsored program. So they will test for free patients who meet criteria for prostate cancer testing using a broad panel of 83 genes. The patient can initiate themselves or the provider can initiate. There is post-test counseling provided free by Invitae, so that eliminates reduces some of the concerns about patient understanding. And then they try to hand the care off to the patient's local provider, which again is helpful in terms of coordinating screening and compliance. The trade-off is that that Invitae is allowed to share this data with third-party providers such as pharma. It does, however, provide a much higher level of counseling and information to the patient than the 23andMe type direct-to-consumer model. So in conclusion, there's a range of testing options and labs that are available for prostate cancer genetics, and careful consideration needs to be given in choosing which of these to use. Thank you.